So this is sort of my agenda and the roadmap for what we'll be talking about. Broadly speaking, the changing landscape, the treatment of HER2-positive breast cancer. A couple of comments about nuances and refinement of how we recognize HER2-positive disease and make sure we keep it under consideration. We'll focus on the overall management changes in metastatic breast cancer among patients who are HER2-positive and the broad range of treatment options they have. This is the timeline going back to late 70s, early 80s when the HER2 signaling pathway was appreciated as an important driver and really conferred a distinct clinical phenotype on breast cancer. Much of that work was done by a variety of investigators. One of the first that really focused on that in the lab was Dennis Slayman. And as a result of his and many other investigators, we started to see the development of targeted therapy towards that pathway, and then the introduction of trastuzumab as a treatment for metastatic disease, both in advanced disease and then ultimately, as you know, in the adjuvant setting. We started to see the emergence of other drugs coming online, including the oral agent lapatinib, and then we also saw more recently the use of pertuzumab and then TDM1, a fusion molecule which we'll talk about, and then the most recent change to the guidelines, of course, is the introduction of pertuzumab as a pre-op therapy, and we'll talk about that towards the end of my talk. A couple of comments just about recognizing HER2-positive disease. In the old days, which is not so long ago, we would look at immunohistochemistry. If you were 3+, you went on to anti-HER2 therapy. If you were FISH positive, you went on to anti-HER2 therapy. But there are a lot of nuances and ambiguity. And without going into much of the detail that is represented by this slide and the next, we've refined how the guidelines look at these test results, hoping to identify the patients who are really going to benefit from anti-HER2 therapy and those that can bypass it. And as you can see, there are reflex pathways that suggest in patients where there's some ambiguity about the first test result, one should go on to a second test that will hopefully clarify things. And that may be whether you're looking at the ratio of HER2 to CYP17. But again, in the end, even after all the reflex testing is done, if there is ambiguity about the status of a patient's HER2 status, we generally defer towards treatment with anti-HER2 therapy as opposed to not using it. And that's based largely on the results of all the data that's come out, not only from the advanced disease setting, but the adjuvant setting, trying to give the patient every benefit they can if you're uncertain about the HER2 status, even after all the testing that's been done. It's important to recognize that not all HER2-positive disease falls into the HER2-enriched intrinsic subtype. So we often think about patients who have luminal A, luminal B, or triple-negative breast cancer as not being anything other than what they're represented to be. And if you look at the intrinsic subtypes, you know, we can't go through a talk like this at an oncology meeting without showing one of these slides, but if you show the intrinsic subtypes and look at them based on the expression or underexpression of certain genes, you can categorize tumors into luminal A, luminal B, the so-called basal-like, sometimes erroneously referred to synonymously as triple-negative breast cancer, and the HER2-enriched subtype on the far right. And very broadly, we think about utilizing certain therapeutics for each of these subsets. So the luminal A's and B's, more often endocrine-directed therapy, the basal subtypes chemotherapy, and then of course the HER2-enriched patients we think of as being subjects that would be most suitable for anti-HER2 therapy. But there is a reality that these intrinsic subtypes may be a little bit promiscuous. So if you look across the pie diagrams that are depicted on this slide from data from Peru and colleagues a few years back, you can see that even among, for instance, the basal subtype, which is in this category, there are a subset of patients who are HER2 positive. And similarly, although the slice of the pie is quite low in luminal A and luminal B, there are subsets of patients within that group that are HER2 overexpressing and may be, again, patients who could be considered for anti-HER2 therapy. So clinical HER2 positive disease is seen across all the intrinsic subtypes. Of course, within the HER2 enriched set of patients, the proportion of patients who are HER2 positive is much greater. So let's transition to metastatic breast cancer, and I think this is where the story started, but for this kind of talk, trying to weave our way in 2015 to where we are and where we've been, you could make the case that we should talk about adjuvant therapy as a predecessor to this slide. This slide really suggests where we are today, and that is we all see HER2 positive metastatic breast cancer in our clinics, but I would submit that if you compare it to 10 or 15 years ago, the frequency of seeing such patients is less. And a lot of that has to do, of course, with the effectiveness of adjuvant HER2 therapy. Because it is effective, we're seeing fewer, not few enough, but we're seeing far fewer patients that develop recurrent HER2 positive breast cancer compared to a generation ago. And as a result, the frequency of having to use first-line therapy has decreased significantly compared to 15 years ago. And if you want to take a walk back in history to see how we've evolved from where we were several years ago with the introduction of the first anti-HER2 therapies in metastatic disease and how the landscape has changed, if you look at the outcome of patients with HER2 positive disease in the absence of any anti-HER2 therapy, the one-year survival was about 70%. In patients who were HER2 negative, survival about 75%. And then with the introduction of trastuzumab, you can see how significantly that survival improved from 70 to 86%. And that early data was based on taxane therapy in conjunction with trastuzumab. And again, for perhaps some of the trainees in the audience, they don't necessarily remember the earliest trials with trastuzumab, which was either combined with anthracycline taxane-based therapy, usually in the form of paclitaxel or docetaxel. But in both cases, there was a significant improvement in the time to disease progression, a much higher response rate, and most importantly, an improvement in overall survival, despite crossover being allowed in the patients who did not get trastuzumab. So this was proof of principle that using a non-chemotherapy targeted therapy could really change the clinical course of patients with HER2 positive disease. If I was giving this talk 5 or 10 years ago, what I would have now gone into are 5 or 10 or 15 slides showing you every combination of trastuzumab with a cytotoxic chemotherapy drug. And at the end of that discussion, I would tell you the following things. And that is that when you combine chemotherapy of any kind with trastuzumab, there didn't appear to be any enhanced toxicity that was evident, and the caveat, of course, is that there was some early data that gave us caution that when you combine trastuzumab with an anthracycline, you could increase the risk of cardiac toxicity. But that aside, if you look at all the other chemotherapy combinations that were executed in conjunction with trastuzumab, they generally showed that there was enhancement in the benefit to patients with the combination over chemotherapy alone, and there were no increase in side effects. And a lot of this was originally based on synergy models that were done preclinically that suggested certain drugs would have enhanced effect with trastuzumab. In reality, drugs like, for instance, 5-FU or capecitabine was not felt to be synergistic with trastuzumab, so there was muted enthusiasm for actually looking at that combination. But there was subsequent work that essentially reaffirmed the idea that if you combine any chemotherapy drug in HER2-positive patients with trastuzumab, you have greater objective findings, clinical benefit, time to disease progression, with the combination over chemotherapy alone. And I would submit that the last bullet point is important. As we have a variety of new drugs that are available, hopefully we won't repeat the exact same exercise, committing ourselves to doing 50 different phase 2 trials of pertuzumab with every chemotherapy drug that we have to demonstrate that you might get increased response rates with the combination. So this is what the guidelines that were released yesterday show. You can't read them, but if you really focus on this part of the box, these are our options for HER2-positive metastatic breast cancer. And it's always nice to have a lot of different options. And if you were to juxtapose this to 15 years ago in the HER2 space, this would be sort of a desert. There wasn't a whole lot going on here. And now you can see that we have a variety of drugs and combinations of anti-HER2 therapy that could be legitimately offered to patients. And there are sequences that we tend to use based on the clinical data that's been generated. If you look at the available drugs for metastatic breast cancer, they fall into those that are known to you: trastuzumab, more recently pertuzumab, and then TDM1. Perhaps neratinib, an oral agent, will be on the horizon. Lapatinib is available, of course. And what we'll be talking about in a few minutes are strategies for patients who progress beyond first or second line anti-HER2 therapy. What are the mechanisms and how do you potentially overcome resistance to those drugs? And it's really these pathways here that are being evaluated to determine if you can use targeted therapy in conjunction with anti-HER2 therapy to overcome the resistance that develops in overexpression or mutation of particular nodes in these pathways: PI3 kinase, AKT, mTOR, etc. So again, how did we get where we are today? Well, we thought we knew the answer to everything without doing clinical trials. A perfect example is 20 years ago, we thought that bone marrow transplant for metastatic breast cancer was the cure for the disease. And in the absence of clinical trials, as you know, there was a blossoming of bone marrow transplant units everywhere in every hospital across the nation. And ultimately, clinical research caught up with the data or the enthusiasm for it, and as you know, the enthusiasm for transplant became significantly diminished to make it almost extinct at this point. The same thing has been shown in many different examples as we develop therapeutics. And in breast cancer, we had the notion that you should continue trastuzumab forever. So the idea was that if you progressed after receiving trastuzumab-based therapy with a chemotherapy agent, you simply switched out the chemotherapy and continued trastuzumab indefinitely. And in reality, that was proven to be correct, and that is something that we continue to do, not necessarily with trastuzumab forever, but the notion that we leverage the anti-HER2 pathway continuously in a patient is something that has been borne out by clinical trials. And the same example was attempted with trying to do trials examining anti-HER2 therapy after progression in patients with metastatic disease. We thought we knew the answer, so the accrual to those early trials failed. And the best we could do was a trial by von Minkwitz. There was a U.S. trial that was being done that had to be closed. But the von Minkwitz trial shown here was an effort to determine whether or not the continuation of trastuzumab beyond disease progression, in which patients either receive capecitabine with no anti-HER2 therapy, or the anti-HER2 therapy with trastuzumab was continued with capecitabine. Did it make a difference in terms of outcome? And as you can see on the slide, even though there was an initial effort to have a much, much larger trial, this trial recruited only 156 patients because so many people were doing what they wanted, and we couldn't actually recruit to the trial either in the U.S. or in this case in Europe. But this trial was ultimately completed to the point where we could get some information from it. And as you can see, for those patients who continued trastuzumab beyond disease progression, there was not only an improvement in response rate when you continue the anti-HER2 therapy, but the time to disease progression was also enhanced. So in a sense, this was proof of principle that continuing to leverage the HER2 pathway was important, that you simply didn't stop it, you should continue the therapy in some form. At about the same time, there was a lot of work being done to develop other drugs, and the oral TKI inhibitor lapatinib was approved based on the results of this trial. These were patients who had received a taxane, trastuzumab, and an anthracycline before, and at the time of progressive HER2-positive metastatic breast cancer, they were randomized either to capecitabine alone or capecitabine plus lapatinib. And what this trial demonstrated, and really resulted in the approval of lapatinib, was capecitabine was inferior to the combination of lapatinib plus capecitabine, again demonstrating that leveraging the anti-HER2 pathway was important. There was a much longer time to disease progression for the patients who had lapatinib added to the chemotherapy, and similarly the response rate was also enhanced with anti-HER2 therapy. Selectively, there are patients where we may be able to avoid chemotherapy or where it's appropriate to avoid chemotherapy based on any of a number of different factors, including performance status, comorbidities, etc. And there is data suggesting that in patients with metastatic HER2 positive disease that you could conceivably use dual targeting with the continuation of trastuzumab and a combination of lapatinib, and that would be superior to simply switching out to lapatinib. And this was based on data that Kim Blackwell presented and published several years ago now in patients who had already progressed on prior chemotherapy and trastuzumab, either randomized to lapatinib alone or lapatinib plus trastuzumab, receiving no chemotherapy. And this trial also demonstrated that, again, although you can't get too excited about the overall response rate that was seen, there was an improvement in time to disease progression favoring dual targeting, continuation of trastuzumab, adding a new anti-HER2 therapy in the form of lapatinib. Again, this is done selectively, probably less so than we did in the past, simply because we have more therapeutics that target the HER2 pathway than we did before. We have an understanding of what drives the HER2 pathway, and I think, as you know, there are a number of family members in the HER2 family, HER1, 2, 3, and 4. You can get homodimerization, but the most potent signaling downstream that occurs is when you get HER2, HER3 heterodimerization. So there were efforts to figure out how could you perturb that heterodimerization and perhaps enhance the anti-tumor effect of these drugs. And to that end, of course, one of the drugs that was sort of on the back burner and quite frankly not as enthusiastically embraced when it was being developed, they were actually more interested in other compounds, was the drug pertuzumab, which we now have available for patients with HER2 positive disease. And as you know, it's a monoclonal antibody. It has a distinct place where it attaches, which is the dimerization domain, which is different than where trastuzumab attaches. It has very modest single-agent activity, but when you combine it with trastuzumab, because they have distinct mechanisms of action, you get synergy with both drugs. And pertuzumab essentially prevents the heterodimerization, and then by extension prevents or diminishes the downstream signaling that occurs because of HER2, HER3 heterodimerization. So skipping over a lot of the early trials and the preclinical work, I think everybody who sees breast cancer patients is familiar with the Cleopatra trial. And this was, in a sense, proof of principle with a newer agent, two antibodies, that dual targeting may enhance the anti-tumor effect and benefit to patients with HER2 metastatic disease who are receiving therapy as first-line treatment. So the randomization in this population was taxane in the form of docetaxel plus trastuzumab, or the triplet of docetaxel, pertuzumab, and trastuzumab. And what the data demonstrated was that there was a significant improvement in progression-free survival favoring dual targeting with pertuzumab and trastuzumab in conjunction with docetaxel of about 6 months, which is shown here. And the most recent update from ESMO last year demonstrated that the final overall survival analysis also dramatically improved with dual targeting with pertuzumab and trastuzumab. And there's relatively few treatment regimens that we have available that can claim to improve the overall survival by in excess of a year in a clinical trial. So that's fairly dramatic. And this firmly placed this combination of drugs, or at least the combination of trastuzumab, pertuzumab, as a legitimate holder of first-line therapy for HER2 positive disease. Now, we always think that when you make cocktails, and this was a comment that we would always have when we talked about combination chemotherapy, you make things complicated, maybe you enhance efficacy. How much of a detriment do you provide to patients by increased side effects? Well, if you look at the adverse effects of these different combinations, either on the left, trastuzumab and chemotherapy, or pertuzumab, trastuzumab, and chemotherapy, what's most striking, and in your experience for those of you who have used this regimen, probably the most common thing that patients experience is some element of diarrhea. Usually it's relatively lower grade. It's usually manageable, but there are patients who will experience diarrhea that's problematic. But for the most part, most of the side effects are not significantly different than patients who receive trastuzumab and chemotherapy alone. So again, it seemed to be well tolerated. And the other important thing that comes out in the early development of trastuzumab and other anti-HER2 therapies is the concern that by targeting HER2, you may be putting the patient at risk for cardiac events. And certainly when you use dual anti-HER2 targeting with trastuzumab and pertuzumab, the data from the Cleopatra trial shows no difference in terms of cardiac toxicity. So that should be reassuring. And of course, we have data from other clinical experiences with these drugs that support the same finding. The guidelines, as you'll notice, and I didn't really put them up to drive home this point, the Cleopatra study uses docetaxel. In the guidelines, we give license to using other taxanes, and the utilization of paclitaxel in combination with trastuzumab and pertuzumab was based largely on a phase 2 experience reported from Memorial that showed, not surprisingly, that you could substitute docetaxel with paclitaxel. You would have the expected side effects related to paclitaxel, no interesting new signals of toxicity. And similarly, there was the same kind of activity, anti-tumor activity, that you would expect and see even with the Cleopatra study. So in the guidelines, we give license, we're not dogmatic, that you must use docetaxel with this combination, that a taxane is what is referred to in the guidelines. Now, can you select? This is obviously expensive at this meeting. There will be a lot of discussion about getting quality, cost containment, a variety of things, optimizing patient care. Can you identify patients who are really going to benefit from this kind of dual targeting therapy? It makes it more complex. It certainly makes it more expensive. And although I try to make the case that the side effect profile is not that much different, there are some increase in side effects. So there have been efforts to look at certain characteristics of the tumor that may define those who are more likely to benefit than not. And one of the pathways that I mentioned earlier that may be important in the HER2 signaling pathway is PI3 kinase. And within the Cleopatra study, Bazelga and his colleagues went back and tried to define whether or not those patients who had either a mutation in PI3 kinase or those who had wild type, did it make any difference in terms of the addition of pertuzumab? In other words, if you had a mutation in PI3 kinase, were you more or less likely to benefit from the addition of pertuzumab to trastuzumab? And although in patients who had mutations in PI3 kinase, there was somewhat of a muted time of progression-free survival, whether you were mutated or had wild type, there was a significant advantage to receiving pertuzumab. So again, so far to date, we haven't been able to identify something characteristic within the tumor that would suggest we can identify a patient who would not benefit from this approach, who has metastatic breast cancer, receiving this kind of therapy as first-line therapy. There's a lot of work being done, including with immune signatures. A paper will be coming out in the JCO looking at this, whether we can identify patients who are those that would benefit from trastuzumab based on certain signatures. But to date, we haven't been able to find something that's clinically useful that we'll be able to employ in clinic next week. All right, the next thing that came along in the development of metastatic disease was TDM1. And I think, again, everyone in the room is familiar with this. This is a unique molecule in the sense that it's a fusion molecule, and there's been work being done in this sort of area for the last 25 years. And actually, the thing that was really the obstacle to developing these drugs is this little thing here, which is the linker. A relatively innocuous piece of the pie in a sense. It's not the active anti-cancer therapy, it's not the targeting molecule trastuzumab, but it's the glue that held the cytotoxic to the antibody. And past attempts to make fusion molecules were hampered because the linker was either unstable and released the cytotoxic early, or the toxin, whatever was being conjugated to the antibody, and as a result, either preclinically animals or clinically patients suffered the consequences with increased toxicity. And if you gave maytansine, which was being developed as monotherapy many, many years ago, to a patient, it was prohibitively toxic. So that's why that drug didn't get any further development. So it's known that this is a very potent anti-tumor agent, I'm referring to maytansine, If you could target it effectively where you wanted it, that would be sort of the holy grail. So to that end, TDM1, which is fused to cytotoxic fused to trastuzumab, attaches to HER2. It's internalized, the lysosome breaks it down, and basically you have M-tanzine, otherwise known as maytansine, going where you want it, in the cell, in the malignant cell, and it's truly targeted therapy via the trastuzumab. The data that led to the approval of this drug was the Amelia study shown here. These were HER2-positive metastatic breast cancer patients who had received prior taxane and trastuzumab therapy. They had to have progressed on metastatic disease or within 6 months of adjuvant therapy, and they either received TDM1 or the usual comparator now, which is capecitabine and lapatinib. And unfortunately, this combination is always compared with new drugs, and it's always the one that seemingly gets beat up by whatever is new. So the data from this trial is demonstrated here, and this trial also showed that TDM1 compared to capecitabine and lapatinib in patients who had been previously treated with anti-HER2 therapy having progressed had a better progression-free survival and also higher overall response rate. And similarly, if you look at the overall survival, that was also enhanced for TDM1 over capecitabine and lapatinib. So based on these data, TDM1 became a treatment choice that was approved for patients in the second-line setting and beyond. The adverse side effects that are associated with each of the treatment arms are predictable. Capecitabine, lapatinib, over here, the typical GI, hand-foot syndrome type side effects. And with TDM1, patients experience modest increases in LFTs, and some patients will experience thrombocytopenia, for which dose adjustments or delays have to be built in if you identify a patient who experiences these things. The Teresa trial, in essence, supported what the Amelia trial showed. And this sort of looks like the old Eribulin development plan. That is TDM1 versus treatment of physician's choice. So you had a variety of things that you could choose from. The patients that were enrolled in this trial were those with HER2-positive metastatic breast cancer who had to have received at least 2 prior HER2 therapies, the median being 4. So these were patients who had gotten significant prior HER2 therapy. And as I said, physicians could choose whatever they wanted, and there was also the opportunity down the line, if the physician wanted to put the patient on TDM1 after the patient progressed. So the data from the Teresa trial showed that, again, compared to whatever the physician creatively came up with in this population, TDM1 resulted in a much better progression-free survival than treatment of physician's choice. And usually within the context of what that category included, it was mostly different chemotherapy combinations with trastuzumab. So TDM1 appeared to be superior and again supported the notion or supported the results of the Amelia trial showing enhanced benefit in patients who had progressed after receiving trastuzumab. So when you start to see pertuzumab available, TDM1 available in first line, then second line, the instinct of oncologists is move it up. Let's see how it works. So to that end, the Marianne trial, which is outlined here, a large trial of 1,000 patients with HER2-positive metastatic breast cancer in the first-line setting, are randomized to a taxane plus trastuzumab, which might be viewed as standard, TDM1, or the combination of TDM1 and pertuzumab. And we have the results from the Wall Street Journal and other places, no medical journals yet, but as you know, this was publicized in December. The top-line results suggested that neither TDM1 plus pertuzumab or either TDM1 arm appeared to be significantly different in terms of PFS compared to trastuzumab and a taxane. So this is certainly not the final word on this. We need to see the actual data, not the press releases. But again, we shouldn't assume always that the newest things will necessarily result in a better outcome. So again, we wait for the results of that trial. At the beginning, I mentioned what the standard therapies that are currently available are, and where a lot of the focus really lies is looking at the signaling pathways that drive resistance and what are the maneuvers that we can utilize to try and overcome resistance. So this pathway is being intensely studied not only in HER2-positive disease, But as you'll hear from Dr. Mayer on Saturday, in patients with ER-positive disease, this is also an important pathway for the development of endocrine resistance. And to that end, there are a number of drugs, a whole list of drugs, PI3 kinase inhibitors, AKT inhibitors, mTOR inhibitors, some of which are currently available, some that are in development. There are also heat shock protein inhibitors, which may be important in overcoming resistance. And we haven't heard the last of small TKIs. I referred to neratinib, but there is also afatinib, and there are a variety of other drugs that are being evaluated either in resistant patients or in efforts to prevent or overcome resistance from currently available anti-HER2 therapies. So that raises the question, can we overcome resistance? Can we modulate it? Can we prevent it? Well, to that end, the Bolero trial, which Ruth O'Regan presented a year or so ago, looked at this question in patients with HER2-positive metastatic breast cancer who had developed resistance to trastuzumab. They were randomized either to an alternative chemotherapy with trastuzumab, vinorelbine, or the triplet of vinorelbine, trastuzumab, and everolimus, the mTOR inhibitor. And again, this is focusing on whether or not you can perturb that pathway in such a way to overcome resistance. And what the Bolero trial showed was that from a statistician standpoint, there was statistical significance favoring the addition of an mTOR inhibitor, in this case everolimus, to the combination of trastuzumab and chemotherapy. I think from a clinician standpoint, we would probably argue, have we really moved the ball downfield that much? Because it's really a change of about 5 weeks that we see with the addition of an mTOR inhibitor. So there wasn't a lot of enthusiasm for embracing this as a strategy that we should put in the guidelines, at least at this point. This has also been looked at in the Bolero 1 trial. And the Bolero trials are a series of trials looking at how mTOR inhibitors can be incorporated in the care of patients with breast cancer. The Bolero 1 trial was actually looking at this more in the first-line setting, so patients did not receive prior therapy for advanced metastatic disease with the exception of endocrine therapy, and they were randomized 2-to-1 with everolimus, paclitaxel, and trastuzumab, or simply paclitaxel and trastuzumab. And the idea here is that if you sort of get a handle on that mTOR node right from the get-go, can you either prevent the development of resistance, enhance the overall benefit? And the data that was presented at ASCO this year, as you can see from this slide, fails to demonstrate that that maneuver really resulted in enhanced outcome for the population as a whole. There was a subset of patients, the hormone receptor negative patients, that maybe there was some benefit. Of course, it's a small subset. It's interesting, but it's not something that we would necessarily incorporate into clinical practice today. Now, the drug that lies in wait, maybe, is the one that we've heard about for the last several years. Hal Burstein presented a paper on a phase 2 result about this drug probably 5 or 6 years ago now, neratinib. And the most striking thing I remember from the presentation is that there was significant diarrhea associated with the drug. That's the takeaway that I walked away from that. They have since, in the development of this drug, not only sold it, but they've developed strategies for managing the diarrhea very aggressively right from the get-go. And as I mentioned earlier, neratinib is an oral agent. It's a pan-ERBB2 kinase inhibitor, so it works across HER1, 2, 3, and 4, and it has been demonstrated to have activity after patients progress on other anti-HER2 agents. The registration trial is far along, and this is what it looks like. We don't have data from this. It's a comparison, again, lapatinib and capecitabine to neratinib and capecitabine. So it could very well be a battle of which one causes the most or least diarrhea, but hopefully the net effect will be better outcome for patients. Now, where we do have a hint of information that makes us optimistic is the so-called I-SPY trials, which are it's a preoperative platform to evaluate new drugs rapidly, find signals, and then take those drugs on to bigger trials, more definitive trials. Laura Esserman is the PI on the overall endeavor from UCSF, and I-SPY also included a trial that looked at paclitaxel neratinib versus paclitaxel trastuzumab in a preoperative setting. So this is not metastatic. But what results we do have, which have been alluded to but not formally published yet, was from the AACR meeting in April of 2014. And if you look across all populations, patients who are HER2 positive as a whole, hormone receptor negative, HER2 positive, hormone receptor positive, the patients who received neratinib seem to have a better pathologic complete response rate. And we'll be getting in a moment into the utility of utilizing PCR as a surrogate for other endpoints, but at least it suggests that neratinib may have significant anti-tumor activity, and whether we can utilize that more broadly in patients with breast cancer remains to be seen based on the registration trial. So what I would submit is, at least with metastatic breast cancer, we have multiple agents that are currently available, several more that are on the horizon, as well as strategies to overcome HER2 resistance, and how we sequence these and wisely use these drugs, because we have many of them, will be the challenge going forward.